One, two, three, we're ready to go. Good afternoon. We've got a pretty full schedule, so we're going to go ahead and get started right away. And the first bill up is House Bill 323, Representative Mathiak, LC 46-1064. Two, three, four, five.
I'm sorry you've been hurting.
No worries.
I know. Gee whiz. Ready, Mr. Chairman?
Yes, ma'am. Thank you.
Thank you so much for letting me go first today. I appreciate it more than you know. Today I bring you House Bill 323. This is a Medigap plan for kind of leveling the playing field for patients that are 65 and under that may have ALS or end-stage renal failure. This bill has been passed in 17 states, so we're right on track, I believe. And where we're headed is to try to allow people under 65 to have a Medigap plan so that they can afford a kidney transplant. Statistics prove that if we can get a kidney, we will be back to work before we know it. So that's kind of the bottom line of all of this. The premiums can be astronomical, as you can understand. 200% sometimes of those caps can be way too outreaching for a patient to be able to afford the 20% that Medicare would not cover. So today I have some folks here that would like to testify. One is a kidney transplant recipient, and she has functioned well in life. I think that her story is very compelling, and I'd like to start there if I can, Mr. Chairman.
You may. I've got a number here signed up.
Okay.
Is there somebody particular needs to go first?
I would like for Christine to go first,
Okay.
if that's okay. Good.
Hi, my name is Christine.
You can come on over here and,
Hey, you can go that mic right there. That'll work.
oh, okay.
Into that
Good.
table.
You need a chair.
Hi, it's working.
Go ahead.
Hello. Okay.
Okay. Thank you.
The mic doesn't slap to you. Could you state your name, please?
My name is Christy Flynn, and I'm from Augusta. I was born with a rare genetic disease that caused undeveloped kidneys and eyes. So I am also legally blind. And for most of my life, was focused on that and overcoming the blindness. But when I turned 25, I had finally found my dream job teaching. But my kidneys failed 3 months into that. And so since then, I was on dialysis for 10 years. And then I got a transplant 7 years ago today. So life has been a bit better. But unfortunately, I'm not able to get off the Medicaid that I'm on because I wouldn't be able to afford the medications I need, and all my other doctor's appointments and things like that. And if I were able to get off Medicaid and get Medigap, I would be able to maybe find a part-time job, have more of a normal life now that I have this gift of a transplant. I'm extremely grateful for Medicaid existing, but I just want some other options now that I have a somewhat more normal life.
Well, thank you very much. Are there any questions? So no questions. Thank you, Christy.
Thank you.
Thank you, Christy. Mr. Chairman, we're talking about 4,000 patients in the state of Georgia that have end-stage renal failure and about 400 that may have ALS. So we're only talking about 25% or so of our population in Georgia. Is Mr. Chris next on that list?
It could be, if you'd
Okay.
like for him to go.
Okay.
Christopher, I'm sorry, I can't read your last name. Richards?
Richards.
Yeah, okay.
Good afternoon. My name is Christopher Richards, and I'm from Douglasville, Georgia. I've been a dialysis patient since the year 2017. For most of those time, it's been kind of rough. I'm married. I'm legally married, but I'm not with my wife. But the reason that we're not divorced is because with me only qualifying for Medicare, I use her private insurance to pay the 20% that Medicare does not pay. So with that being said, I'm like in a catch-22 because I need the 20% to pay, because with only getting disability, then there's no way that I could afford the 20% that I have to pay. It's been rough, but I'm dealing with it.
Any questions? Thank you very much for coming. I appreciate you.
Mr. Chairman, that's about 1% a month for that that extra insurance, which would cost about $2 a month extra for somebody that would have that Medigap insurance.
Who else do you want next off this list?
I'd like Miss Lively next, if that's okay.
Elizabeth Lively?
Good afternoon, Chairman Hawkins, Vice Chair Kelly, and members of the committee. My name is Elizabeth Lively, and I'm the Eastern Region Advocacy Director for Dialysis Patient Citizens. We're the largest nonprofit patient advocacy organization in the country that works on behalf of end-stage renal disease. I'm here testifying in support of House Bill 323, which provides affordable access to under 65 Georgians with ESRD and ALS. Thank you, Representative, for your sponsorship. This bill is the same language as Senate Bill 215. That bill passed in Indiana last session unanimously in the Indiana Senate. It went to the House and it passed in the House almost unanimously. There were 2 no votes. And that bill language has been offered to the Insurance Association here as a compromise to the bill that we put up last year. What that bill does, there's 10 Medigap plans. They're lettered plans, A through N. And this bill has plan A, B, and D. So 3 of the 10 plans that these patients could purchase at a premium the same as age 65. The other 7 plans would be available for them to purchase at 200% of what somebody age 65 pays. To give you an example of the premiums that exist now, because Georgia provides guaranteed issue access to these plans, but there's no premium protection in place. So right now, there's a plan out there for Plan A that if you were 65, you would pay $148 a month. That's reasonable. If you were age 64, you would pay $2,222 a month. Who can afford that? Nobody can. That explains why so many Georgians spend down their assets into poverty to go onto the Medicaid program. Our HMA actuarial report, in addition to the premiums that Representative Mathiak mentioned, also looked at the Medicaid spend down for the state. Right now, 55% of dialysis patients are on the state's Medicaid program. The HMA actuarial study, which is an independent third-party actuarial firm, they estimate that 1 in 4 Georgians who are not on Medicaid, this bill would prevent them from spending down. That would mean a savings to the state's Medicaid program over 10 years. I'm sorry, over 5 years of $6.3 million. Those are real dollars, okay? We're talking about 3,800 ESRD patients, and those individuals would be going into the overall Medigap pool of 378,000 people. So you can see why the insurance premium increase to the overall pool, should this bill be passed, would only be $2 a month. It's simple math. It's time that the state stops subsidizing private insurance companies, because right now these people don't have access to Medigap. They're spending down their income. They're going on to the state's Medicaid program. So I urge your support of House Bill 323.
Thank you. Any questions? Who else you want to come up here now? Who else would you
I
like?
think that's it.
I've got,
I've got one more.
yeah, Alexander. You got
Okay.
2 more, eh?
Yes.
Yeah, 1 more.
I didn't realize I had 2 more.
Yeah. She's got 1 more. Who's not?
Chairman Hawkins, Vice Chairman Kelly, and distinguished members of this committee. My name is Richard McDaniel, and I'm here today representing the American Kidney Fund, speaking on behalf of nearly 29,000 Georgians living with kidney failure. Many of you know me from my time in these very halls, working on campaigns, legislative issues. But 5 years ago, my life changed dramatically when my kidneys failed. The journey since then has been devastating, both physically and financially. I've endured multiple extended hospital stays, some lasting weeks at a time. I've been in intensive care, on a ventilator, fighting for my life. My left arm alone has undergone 12 surgical procedures. Each one of these stays, each procedure, each fight for survival has come with its own cost, not just in dollars, but in opportunities lost. This disease doesn't just affect the patient, it impacts entire families. My wife, who was here at the time, was my fiance when this journey first started. It has put her through the ringer, and to see and watch me struggle, seeing the pain in her eyes when I'm suffering cuts deeper than the needles that are placed in my arm 3 times a week. The physical and mental toll extends far beyond just me. Like many others with this disease, I've had to step back from my career and watch my life savings disappear. But beyond the career and financial impact, what weighs heavily on me is how this disease has affected my personal dreams. I've always hoped to become a father one day, but right now, I can't even consider that possibility. The physical demands of dialysis, the constant medical procedures, and the financial strain have put that dream on hold indefinitely. I'm a numbers guy. The numbers tell part of the story. Medicare covers 80% of medical costs for kidney failure patients, leaving us with about $17,000 per year out-of-pocket costs. In Georgia, kidney patients under 65 are charged up to 900% more for Medigap plans than those over 65. I personally pay $3,500 every 3 months for my Medigap plan. Think about that cost for a moment. The average income of kidney patients receiving assistance is less than $28,000 per year. That's because 80% of dialysis patients become too sick to work full time. Not always because of their condition, but often because they can't afford the coverage that will help them stay healthy enough to work. I personally pay $3,500 every 3 months for my USAA Medigap plan, which is covered by the American Kidney Fund's Health Insurance Premium Assistance Program. Without this assistance, I simply couldn't afford this vital coverage. This creates a painful cycle without affordable Medigap coverage. Many patients can't qualify for kidney transplants because they're considered underinsured. Without transplants, they're stuck on dialysis, which costs Medicare over $93,000 per year per patient. Right now, about 4,000 Georgians are waiting for kidney transplants, but only 1 in 6 will get one. The bottom line is clear. The current system traps patients in a cycle of dialysis, prevents them from receiving life-changing transplants, and ultimately costs taxpayers more money. You know, every time I'm connected to the dialysis machine, I watch 2 needles, one red, one blue, work together to clean my blood and keep me alive. Much like that process, kidney disease doesn't care about political parties. It affects Republicans and Democrats alike, rich and poor, urban and rural Georgians. And just like those two lines working together in my arm, I believe that we can find a bipartisan solution that promotes health and wellness for all underserved neighbors. That process of working together can start right here in this room with you as leaders. The decision you make today will ripple far beyond the legislative session. They'll touch the lives of the next generation of Georgians. Young people watching how their elected officials respond to healthcare challenges will remember who stood up for their families and neighbors. This is your opportunity to show them what leadership truly means, coming together to solve the problems that affect all our communities. As Georgia celebrates its 11th year as the #1 state for business, we need to make sure our healthcare policies help maintain that edge. But more importantly, we need to ensure that hardworking Georgians aren't forced to give up their careers, drain their savings, and abandon their dreams because of kidney failure. I'm honored to appear before this distinguished committee, and I thank you for considering this important issue that affects so many of your constituents.
Thank you, sir. Any questions? Thank you for your testimony. Very good. One more?
One more, our ALS patient.
This is Alex, right?
Yes, sir.
Thank you, Mr. Chairman and members of the committee, and thank you, Representative, for sponsoring this important bill. My name is Alex Meixner, and I work as the VP of State Policy for the ALS Association. Now, a quick word about ALS. I don't know how familiar you might be, but amyotrophic lateral sclerosis, or Lou Gehrig's disease, is an always fatal neurodegenerative disease that normally takes 1 to 2 years to diagnose and leaves the patient with a life expectancy of between 3 to 5 years. During that time, the health trials these patients go through are immense, matched only by the financial trials they also have to go through. Pretty much every ALS patient I have spoken to, and I tried to find one who was physically able to be here today, but sadly we couldn't make schedules work. But pretty much every ALS patient I've spoken to ends up spending down all their savings, their kids' retirement, their kids' college funds, their retirement funds, sell their house, do their GoFundMe, you name it. And many still end up going broke, having to declare bankruptcy, and then going on to Medicaid rolls. About 30% generally end up on Medicaid rolls after they spend down all their assets. Now, most of this is because of that 20% gap. You can be 22 years old, and I've met 22-year-olds with ALS, and instantly have access to Medicare. It is one of the only conditions that has a federal fast lane to getting Medicare eligibility. But the federal protections that allow a 65-year-old to get a Medigap plan that's affordable don't extend to the under 65 community. That's why 17 states have passed laws just like this to make sure that the playing field is even. Because we don't want a situation like we have now, where we've got folks who are essentially being penalized for getting sick while they're still young. If they had gotten sick when they were 65, they could get the affordable insurance they need. But if they get sick when they're 25 or 35 or 45 or 55, they're out of luck. They're kind of, doubly cursed. They've got this dreaded disease, plus they're likely to lose their house, lose their savings, everything else. So that is the reason we're here today. A couple of notes of what this bill would do. There's about 960 Georgians currently with ALS. About 400 of those are under the age of 65. This bill would, again, make sure that they have access to buy the same Medigap plans that the over 65 community can do, and make sure that those plans are affordable. Again, they can buy plans right now, but you can do a list. The Medicare.gov has a great price comparison tool, and you can go down the list from UHC to Allstate to Anthem to Cigna, Humana, et cetera. They are all at least 10%, or I'm sorry, 10 times more expensive, right? So again, if you wanted Cigna, for instance, instead of $148 a month, you're paying $1,481. If you wanted Allstate, instead of $152, you're paying $1,599. If you wanted Anthem, instead of $120 a month for a plan A, you're paying $1,766 a month. Now, the impact of this bill would raise premiums for the whole pool, but again, it's about 1% or about $2 a month. Now, that has to be set against the expected annual rate increase. Generally, all Medigap plans go up somewhere in the neighborhood of 4 to 6% a year. I talked to a Georgia insurance broker just on Friday, I believe it was, and he was giving me a few numbers. And for instance, Anthem for the last 2 years has gone up about 10% each year. The 5 years prior to that, it was about a 6% increase each year. So a 1% increase is pretty minimal when taken in account of the expected annual increases here. And again, the impact for these patients is night and day. It is the difference between leaving behind a stack of debt or leaving their kids, their families, their loved ones in a position to move on and move forward without being beholden to medical debt long after their loved one had passed. So again, I would urge you to support this bill. And I will say one more thing, because it's something we've heard in state after state. And this is, again, a road-tested policy. These policies are on the books. The one we passed in Indiana last year went into effect on January 1. I was on an Indiana support group call just last week and listening to folks who've now been able to get insurance coverage for the first time. It was a jubilee. They were just, again, just shocked at the difference that it is making in their outlook and the amount of time that they don't have to spend on the phone with their current insurance company trying to get something covered after denial, after denial, after denial. So I would make just one last point. One of the things we've often heard is that bills like this would negatively impact seniors. I reached out to AARP last week to see if they had a position on this, and they're neutral on it. In some states, they actually have been supportive of these bills because it is a negligible impact on seniors. It is not a significant impact. If this was significant, they would be opposing it. They're not. That should tell you all you need to know about the impact this bill would have on seniors. Thank you very much. Happy to take any questions.
Thank you. You have a question. Representative Petrie.
Thank you, Mr. Chairman. Actually, I have a question for the author. Is it not true that what you're really trying to do here is for those individuals that qualify for Medicare to bring parity to those over 65 and under 65?
It's really a parity for under 65.
Right, to bring them up.
Right, so that they're, like he said, the Medigap A, B, and D would be well over $1,000, sometimes over almost $3,000. So that's what we're trying to do, is just fix it so that they're not having to spend, hold on, make sure I get this right, $16,000 to $28,000 to be able to have a transplant. That's their 20% of the surgery. So that's what we're trying to do here.
But and also, so as somebody who served individuals on Medicaid for my whole career, isn't it true that anytime we allow people to find private ways of providing for their needs, we keep them off Medicaid, and therefore they're less of a burden on taxpayers? Isn't that generally always true?
Yes, sir. And the other thing too, the one of the reasons that I'm excited about this bill is those patients after their transplant are usually back to work within 3 years. So there we have ready workforce ready to go.
Thank you.
Representative Clark.
Thank you, Mr. Chair. Thank you so much for your testimony and for educating us about ALS. I looked through the bill and maybe I'm just missing it. Is ALS a patient that are under 65? Would they be covered under this because of the word disability in here? Because there is no mention of ALS anywhere in the bill.
Exactly so. So the way it works within federal law is ALS patients access Medicare through the disability carve-out. Normally, if you're on disability for 24 consecutive months, you can qualify for Medicare under age 65. Now, almost all of those individuals are going to be on Medicaid, frankly. About 8-10 years ago, Congress passed a law to create a fast lane for ALS patients. So instead of needing to wait that 24 months, which again could be the majority of the life they've got left, As soon as they've got that ALS diagnosis, they are instantly qualified for Medicare under the disability federal pathway.
Thank you. Representative Newton.
Thank you, Mr. Chairman, and thank you for the bill. I know that this is amazing work. I have a friend with ALS and know tons of patients with kidney or they're waiting for transplants as well. It's a little bit of a follow-up. We've included all disabilities that qualify for Medicare in this. It could be intractable back pain, PTSD, other kinds of things too, or is this still narrowly tailored for the two that are mentioned in the title about ALS and chronic kidney disease?
So
Or this may be for the author more than
Go ahead.
either one of you.
sure. Well, I get started.
You can start now.
Read it up.
I'll end.
Perfect. So the way this works in this bill and the way it works again in the 17 states that already have similar laws on the books, the disability community, the broader disability community, don't generally take access for this. They get their coverage via different means, often via a Medicaid waiver or a different program. They don't go in for this. And that's the reason you won't see the disability rights groups, for instance, here testifying either. When we've gone and talked to them in other states, they've said, well, frankly, our folks don't need this. Therefore, we don't really have a position, because it is these two populations of ALS and end-stage renal that are the ones that are outside of that, where they have not yet spent down to qualify for Medicaid, or they're not on a different insurance program.
Thank you. That's a good point, because a lot of those others, as you mentioned, might have not been they've been unemployable by definition, and these are ones that hit more suddenly and dramatically. Thank you for the bill.
Representative Schofield.
Yeah, thank you, Mr. Chair. So just to follow up to Chairman Newton, will lupus nephritis be covered under this?
That's a great question, and unfortunately, I don't know offhand.
Okay.
Okay. We have someone else that wants to speak to the bill. Jesse Wethington.
Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the president of the Georgia Association of Health Plans. We're here today to rise in opposition to House Bill 323 as written. Respectfully, I've spoken with my friend, the author, Representative Mathiak, about our concerns with this bill, and they really do come down to the math. There is an impact to individuals who are in that group of people over 75 that are significantly more numerous. When this has been looked at in some other marketplaces, there were non-negligible increases to premiums for those individuals in that group of 300,000 people that were over the age of 65 in order to subsidize this smaller group of individuals who would benefit from this bill. Of course, when you move the money around, it does become more expensive for those. There would also be an impact that hasn't been mentioned, which was a lot of those individuals who are on fixed or limited incomes would then drop their coverage when it becomes unaffordable for them. And so they would then be exposed to their total cost sharing amount without having that Medicare supplemental policy being affordable for them at that point. I do think this is one we may be able to come to a compromise as this works through the process. We have offered the state of Nebraska's version of this bill as a potential compromise, but that's something we're still having conversations about. And we feel like really the amount of that subsidy, cross subsidy, and then the number of plans that would be required to be offered under this version of the bill would be too much of a burden. And not all of our members offer Medicare supplemental policies in the state. A subset do, but they felt concerned enough about this for us to want to register our concerns with the committee. So thank you, Mr. Chairman.
Representative Newton.
Thank you, Mr. Chairman. Appreciate your input on this. Do you have an approximate number of the 65 and up that are on these plans? Because I know we've heard numbers of 4,000 and maybe 900 that are on chronic kidney disease, kidney failure, and
north of 300,000, I think, is what's currently on a over 65 Medicare supplement plan today.
Over 300,000, and these 4,600 or 4,900 additional. You're saying that would move rates significantly?
So when the Washington Department of Insurance looked at this in 2022, they estimated some of the portions of this bill would result in a 16% increase, which is about a $300 to $515 per year increase in premiums for those impacted in the over 65 group. Again, these are very, very expensive treatments, as you heard, $93,000 a year. For course, dialysis, kidney transplants can be over $120,000. You only have 4,000, 5,000 people who are currently in that pool of the under 65s. You'd expect that PMPM to be pretty large.
Senator Clark.
Thank you, Mr. Chair. I just want to clarify, over 300,000 people or over 300,000 Georgians are already using the Medicare supplement. Is that what you said?
Over 65, yes, ma'am.
Over the 65. And you're saying that if this bill were to pass, that it could result in a premium increase of about $300 per year, according to data from another state? Is that what
This
you're
was an
saying?
estimate.
It's an estimate. Other people who testified earlier said that the premiums increase would be a lot smaller than that. Can you probably help me with this, and what's the discrepancy here? Like,
Sure.
why is there such a big gap between what you're saying and what the other group said?
So we've used HMA before to do studies. We've used Milliman as well. Milliman was the group that did the Washington State analysis. So we haven't done a direct premium analysis for this on our companies that do offer Medicare supplement plans. That's just what we feel is a reasonable estimate. That's happened in another jurisdiction that's done pieces of this.
Thank you.
Representative Schofield.
Thank you. Thank you. And I guess I'm going to ask a clarifying question. You said that's what you feel, but is there hardcore data and evidence that you can provide to this committee?
I'll provide the Washington State DOI report to the chairman and the staff. That will be sufficient.
All right. And then I'm just curious about the Nebraska plan. Can you speak to that a little bit about, does it include the end-stage renal disease, or any other plans? Is it just often one?
So that state has a single plan. It would cover the individuals that are both in end-stage renal disease and ALS. And then there's a rating limit of, I think, 150% in Nebraska. And so that's the core difference.
Thank you.
Thank you. Would the author like to wrap up?
Yes, I would. It's my understanding that Nebraska excludes end-stage renal, is my understanding. Could I bring Elizabeth back up? Because she's better at the actuarial.
It needs to be short. We've got a bunch of
And I
legislation.
understand that, Mr. Chairman, but I'd like to just, because they're asking some pretty pertinent questions actuarially that I think Elizabeth can do a way better job. Thank you.
Okay, Elizabeth.
Thank you, Mr. Chairman. Nebraska does indeed exclude ESRD, and in fact, there is a hearing today in the state of Nebraska on a bill to put ESRD back into that statute. A comment on the state of Washington. The state of Washington, their premiums are based on community rating. That is the gold standard, and it is the best number for a patient who is paying that premium, but it also ends up being a more expensive option. Okay, so New York is community rated, Connecticut is community rated, the state of Washington is community rated. So Mr. Wetherington is really comparing apples to oranges here. This actuarial study here is using 2022 Medicare claims data. It's the most current data available. These 3,800 people, they are covered by Medicare, not by Medicaid, okay? These are people who earn too much money to go onto Medicaid, and this bill will prevent them from spending down. So you can think about the impact to the larger pool of the 378,000. It's going to be about $2 a month, all right? And for the state of Georgia, they're going to be able to save $6.3 million by keeping 1 in 4 of these patients off of the Medicaid rolls over the next 5 years.
Okay, thank you. Okay, I see no questions. Thank you, Representative Majdiak. Do we have a motion?
Move to pass.
Yes, do I hear a second? All those in favor say aye.
Aye.
All those against say nay. Looks like your bill just passed.
Thank
You
you.
got a do
Thank you,
pass
everybody.
LC 461064.
Kidney patients and ALS patients, thank you very much.
Thank you. Okay, next up, substitute to House Bill 54. It's Representative Clark, LC 520773S.
Chairman and committee members, I bring before you today House Bill 54, and it has to do with home health services. We discussed it last year in committee a good bit. I've sat down. We've had some more discussions, refining it and all that. On this, the substitute you have before you, it's allowing PAs to sign home health services, which that I know of. Every state allows PAs to in the protocol agreement to be able to sign home health services. So it will allow that. And also Georgia ranks 7th among states. The baby boomer population as they're aging. So we have a big population of that. Also in the Rural Health Information Hub, it says access to home health services is important for people with chronic conditions or disabilities and those who need short-term nursing and or rehabilitation services after being discharged from the hospital. Many rural people depend on home health services to attain a degree of independence and to avoid or delay hospitalization or moving to a nursing home or assisted living facility. This type of care is less costly than hospitalization or post-acute care, improves recovery and well-being, and eliminates the need to travel for appropriate services. However, rural populations are at risk of having inadequate access to affordable home health services. And I think we have amazing health services overall here in the metro, but especially in the rural, I think it's have a huge impact. And then also, we have right now about 4,000 PAs in Georgia. And also in 2020, the Federal CARES Act permanently authorized PAs to order home health services for patients, assuming the states allow them to. So this would just allow PAs to be able to sign home health services. And we worked with Maginal and sat down with them to discuss this legislation. So we should that I know of well in agreement, and they're fine with the bill and support it.
Questions? Representative Newt.
Thank you, Mr. Chairman. I appreciate in this bill that the physician assistants are working under the supervision of a physician according to the code section, I guess in line 31 that you mentioned, 43-34-103. And I appreciate that. I know there's a lot that we would like to do, but on expanding the abilities of people to work. But at the same time, some of these are individuals, the patients are just shy of needing assisted living or skilled nursing when they're at home with a home treatment plan. And I appreciate that including the physician into that because and working as a team with the PA, I think is a great way to make sure that there's nothing being missed in patients who can be on 8 to 10 medications. And I appreciate the bill. Thank you, sir.
We have up to speak to the bill, Tim Davis. Is Tim here?
I'll be brief. Tim Davis, thank you, Chair. You support the bill.
Okay, thank you. Did you have a question?
I like it.
Do you have a question?
Yeah, so I'll just make a comment.
Thank you, Chairman. And I just wanted to say that obviously we took this up last year. I actually, having done home care for a long time, and this is home health, so not to be confused with home care. But oftentimes physicians are too busy. These people work underneath the supervision of a physician. Individuals that are on the, as Doc Newton just pointed out, these are oftentimes individuals who are on the precipice of long-term care. They need to be served immediately. This makes immense sense. I actually supported it with nurse practitioners as well. But at any rate, that's now I digress. But I support the measure fully for all those reasons.
Okay, thank you. Up to speak to the bill is Sheila Hubbardstone.
Mr. Chairman, members of the committee, my name is Sheila Humberstone, with Stonebridge Consulting. I'm here today on behalf of GAPA, Georgia Association of Physicians Assistants, and I want to commend the author for the bill and implore you to to support the bill as it continues on its path. I think what you've heard is exactly right. We're all trying to provide the right care in the right place at the right time, and this just allows us to open those doorways wider to see more patients. And physician assistants do work under a very specific job description with their supervising physicians. So we don't do anything that's not sort of signed off and authorized by the supervising physician to give us that authority. So that collaborative model works well, and we implore you to continue to allow us to work to the top of that license. Can answer any questions for you.
Thank you. Any questions? I see none. Do I hear a motion?
Thank you.
Second? All those in favor say aye. All those against say nay. Congratulations, you have a due pass on LC 520773S. And if you want to stay right there, we'll do your next bill, which is House Bill 87, LC 520770S.
Thank you, Mr. Chairman. With House Bill 87, I know we talked last in committee, and I know the committee was very excited about the bill and supportive, but we had a few things just to work on. We're also waiting for a fiscal note. So we made the changes to ensure financial responsibility while keeping a strong healthcare standards. We worked with the Georgia Association of Health Plans and the Georgia Society of Prosthesis and Orthotists to redefine the meaning of medical necessity and set fair limits by following the national standards, including those used by the VA. We ensure efficiency and avoid unnecessary costs. To address the concerns about the state healthcare benefit plan, we added a section. It's right, you can see it right, section 2.
Right.
It adds
109,
the coverage.
Right.
Say again.
I said line 109, 110 for the committee.
Yep. And it would depend on future funding, preventing unexpected costs for the state. Also, the fiscal note is being reviewed by the GSOP to reflect the updated definition of medical necessity, ensuring transparency and responsible use of taxpayer money. This updated bill balances essential support for people with prosthetic and orthotic needs while staying financially responsible. It helps individuals stay independent without adding extra cost to the state by following proven medical standards and keeping budget safeguards. We provide effective care while respecting the need for limited government and smart spending. And passing this bill brings Georgians with limb loss and limb differences closer to life-changing devices that improve their well-being. And so we'll take any questions you might have, but we've worked with the insurance companies, and we're all in agreement.
Very good job. Any questions? Seeing none, do I hear a motion? Do I hear a second? All those in favor say aye. All those opposed say nay. Do pass on LC 520770S. Thank you, Representative Clark. Up next, House Bill 428, Representative Franklin, LC 1090, 461090. And then for Europe.
Mr. Chairman, members of committee, I do really appreciate the opportunity to present this bill to you today. This whole process for me has been a blessing, so I'm really happy to be able to share it with you. Mr. Chairman, if you permit, before I get into the bill, I'd like to share with you a little bit of my personal experience, and I have two other families here that I would like them to share as well. But I know your time is limited, and we can make it very brief if you let us. But my story is that my wife and I got married late in life. We've been married about 10 years, and we've never married before, never had children before. And when we got married, we didn't really think about family planning. We were just being married, and we didn't consider the fact that we might not be able to have children. 2 years into the marriage, we were unable to have children, and we started looking at other options. We looked into everything that was available, and IVF, of course, was one of them. So we started to do that process, and we've tried IVF multiple times. We've had failures at it, and then we tried to adopt, and then that fell through. We actually got about 2 weeks away from the adoption process, which was just an event in itself, and that fell apart. And you can imagine kind of the roller coaster ride that my wife and I had during this process, during this time. But I'm happy to say now, report to you now that my wife is pregnant through IVF. We're due a little girl on June the 3rd. So we're ecstatic about that and very happy. And I truly believe that she would not be pregnant if we did not use IVF. And so when I got the opportunity to present this bill, I jumped on it, and I was ecstatic about doing it because I know firsthand how important this is to Georgia and Georgian families. And if I could, I've got two other families here that have similar but different stories. And like I said, if you could make it really brief, I would like to have them share theirs.
Go ahead.
Yeah, go ahead.
Andrea Kerr. Okay.
Thank you. I'll be very brief. Good afternoon, members of the Health and Human Services Committee. Thank you for allowing us to share our voices with you today. I'm honored to be here and ever so grateful for the science and marvel of IVF. We are here to urge your support for House Bill 428. I'm Andrea Kerr, and alongside my husband, Patrick, we are the proud parents of Benjamin, Elliot, and Gavin. For a long time, we wondered if we would ever be fortunate to know our children. But thanks to IVF, we do. This week marks 15 years since we sought fertility treatment. We relied on the expertise of Dr. Catherine Calhoun at the Atlanta Center for Reproductive Medicine after years of family planning on our own, to no avail. Our 5-year journey with Dr. Calhoun was marked by the excitement of treatment cycles that worked, and then it was coupled with the devastation when those cycles failed. We lost pregnancies, one after another, after another, after another. Without going through this process, I don't know that I would have had the appreciation for all the small things that lead to a successful pregnancy and birth. However difficult our path to parenthood had become, Dr. Calhoun persevered, and so did we. We could have given up. We had every reason to do so. But we trusted the science, and we trusted her. Patrick and I brought home our first son in 2015. Twin boys joined us the following year. Our home is loud and happy, and it's full, and in vitro fertilization is the perfect combination of hoping and wishing for something when it's not guaranteed. We bet on ourselves and dedicated all of our resources, emotionally, financially, to something when the odds were firmly stacked against us. It's the ultimate act of trust, trusting experts who dedicate their careers, their livelihood, to ensuring that people like me have a chance to create a legacy. In vitro fertilization is more than the scientific protocols, medications, appointments, and surgeries. It's finally being able to hang the extra Christmas stocking on the fireplace mantle after saving it for one day just in case. It's decorating our nursery after the upstairs room sat dark and empty and cold for years. Teaching my kids how to ride a bike. It's watching them barrel down the stairs on Christmas morning. It's cheering them on at their Little League baseball games. It's singing happy birthday over a cake and watching your firstborn child blow out his candles. None of this would have been possible without the science, the expertise of our providers, one of them behind me, and the legislature that protects it all. I'd like to thank Speaker John Burns for prioritizing this for Georgians, Lehman Franklin for bringing the bill, and to you all for hearing me today. I urge you to vote yes on this bill. Thank you.
Thank you. Ellie Flagler. No, it's not Ellie then.
I am Ellie Engler. I know you're looking at the sheet trying to figure out that I am a man and not a woman.
Yeah, rather than
I joke I have 3 brothers, but I am my mother's daughter. So that is just how it is. I am speaking about IVF, which most people think is a female subject, and it is not. It takes 2 to tango, and I was part of this issue. And so my wife calls me Chandler for friends because when I get nervous, I make jokes. So it is a very serious topic. But, I'm sitting here and I'm a long time listener, first time, caller. And I am lucky enough to also have three children. I have an 11-year-old, I have a 9-year-old, and I have a 7-year-old girl this week. And it took us some time. I have three brothers. No one else in my family, no one else in my wife's family had any issues. We just thought this was, I tell my mother college would have looked really different if I knew this was a problem for me. But yeah, see, you guys get it. You guys get it. And yeah, I'm sorry. I told you. We got doctors and everything here, but one of the hardest things I probably faced in my life was this, and was being a husband to something that you don't have any control over. Probably the worst feelings as a husband could ever have is having to look at your wife month after month, failed attempts. And so we're really great. We did other things before IVF, but we were really grateful that it worked for us. We know it doesn't work for everyone, but we were super thankful. We had two kids, and my wife got sick after our second kid, and we spent a lot of time out of the hospital. She had a spinal issue, and they told us that she would never have kids again. And she was so tough that she didn't cry one time during this whole spinal thing. We didn't know how it was going to go. It was touch and go for a little while. And the first time that she broke, she told us, when the doctor told us that we weren't going to have a third kid, I told her they were wrong. They're just doctors. No disrespect. You guys are great. And we waited our time after she got better, and thankfully they saved her. And we were lucky enough to be blessed with our youngest, Hannah, who just turned 7. And so we have 3 amazing children. And I don't know, they changed our world, and they're slowly changing the world one person at a time. So thank you, Chairman and Speaker. Thank you to the sponsor for putting this bill in front of you today. And hope we hear another yay. Let's keep the good times rolling. Thank you so much.
Thank you very much. Wrap up.
Yes, sir. So I just wanted you to hear those stories, because they're just 2 or 3, with me included, of hundreds that have similar situations in Georgia. And I wanted you to hear the human side of this and how great this legislation can be. But we're not asking in this bill to do anything that's not already happening in Georgia. All we're doing is codifying the language for it so that we can have it safe and secure in Georgia for Georgians, and that's it. I've been up here long enough to know that you could get involved in all the satellite issues and discussions of an issue on a bill, and you could give up the great for the good. This does not dive into it. It's simple, in the simplest form as it could be. It goes straight to the heart of the matter of codifying the language, and that's all it does.
Sure.
So I ask for your favorable support for you and this committee.
Thank you. I see no questions. Do I hear a motion?
Move to pass.
Second. All those in favor say aye. All those opposed? Congratulations. You have a due pass on LC 461090.
Thank you, sir. Appreciate it.
Okay, up next is a substitute to House Bill 298, Representative Kelly.
Go over there.
I don't care. You can do it right there if you want.
Oh, I did hear.
Yeah, that's fine.
Great. Thank you, Mr. Chairman, members of the committee. I come before you today with LC 461145S. I'm going to say at the beginning, this legislation was never meant in any way to say hospital facilities are not doing the right thing, that we're not taking care of our nurses, because I've really enjoyed the opportunity I've had working with the nurses who've been involved with this legislation and the executives and the organizations that represent the hospitals. What my desire with this legislation was simply to try and codify some of the best practices that are currently existing that we've seen work in our hospitals, and make sure that we are implementing those across our hospital community. And simply what we're doing here, Mr. Chairman, is setting up codifying some language to set up a nurse services staffing plan, creating a nurse staffing committee, and then an advisory committee statewide that will have people from the Speaker, the Lieutenant Governor, and the Governor point to further make recommendations to us as what we can do to support our nurses and more importantly, our patients across the state. That's something that's important to me is we're keeping the patients at the forefront of this. But I certainly think that our nursing community plays a vital role in that. Mr. Chairman, I know there's going to be others that want to testify and I'll let them speak and I'll be glad to come back with any questions regarding the subject of the bill.
Tim Davis, you want to come up?
Thank you, Chairman and committee. My name is Tim Davis. I'm the Director of Government Affairs at the Georgia Nurses Association. Grateful to Vice Chairman Kelly for bringing this legislation on behalf of the 170,000 plus nurses in our state who just want to feel like valuable assets to their employers. We think this bill gives them the ability to give valued feedback direct from the front lines of healthcare when employers are making staffing decisions around the hospital. And so at the appropriate time, we would ask for your favorable consideration and support for this bill.
Thank you. Any questions? Do I hear a motion? Do I hear a second? Before we vote, we have two amendments before us. On line 76, the amendment is to change 50 to 75%. So it would read, provide direct patient care during at least 75% of their work time. The Second Amendment applies to 147, 152, and 165, putting a 2 after C, so it'd be 2 representatives, adding an S to representatives, striking the A on each one of those lines. Right? Oh, you go over that again? Okay. I'm sorry, what?
3 places we're going to do tonight.
Right, 3 places, lines 147, add a 2 after the C, so it'll be 2 representatives, striking the A. On 152, the same thing, 2 striking A representatives. And on line 156, striking the A, 2 representatives, add an S to representatives. Do I hear?
That's your amendment, Mr. Chairman?
Yes, sir.
I'll second it, man.
Okay, all those in favor of the amendment say yay.
Aye.
All those against? Okay, amendments passed. Now to the main body of the bill. All those in favor of the substitute HB 298. All those in favor say aye.
Aye.
All those against say nay. We have a due pass on LC 461145S. Thank you, sir.
Tell your mama.
All right, up to our last bill. Yeah, this little small bill. That's what I'm taking about. House Bill 139, Representative Jones. Okay, let's take a 5-minute break. Let me text him. He's in 3 committees at one time. All right, let's come back to order, please. Excuse me, we still got one more bill to go, a little small one, right? Representative Todd Jones, the floor is yours.
Mr. Chairman, thank you very much. And to members of the committee, first and foremost, I would like to apologize. For better or for worse, at 2 p.m., I had 4 committees scheduled. I tried to keep up with all 4 of them. And as you can probably see from the 5-minute break, I wasn't able to keep up with where health was at. First and foremost, I come to you with House Bill 139, LC 461023. This is a little small bill with not much interest from outside parties. At least we get one laugh before we get into this serious conversation. But in all seriousness, if it's okay with you, Dr. Hawkins, what I'd like to do before I go in a sense line by line, not completely line by line, sir.
Right,
but,
you're not doing line by line.
Yeah, I agree. But before we get into what is a relatively short bill, 39 lines, I felt as if without an understanding of 340B, and trust me, it's just a few slides, it needs to be put into context before we start talking about covered entities, covered pharmacies, et cetera. So with your permission, sir, I'd like to do that.
Go ahead.
Okay, thank you. And no tech person would do anything without PowerPoint. Go by the cover slide. So real quick for everybody, for those of you who not know, this is a federal statute that was established over 3 decades ago. It's overseen by HRSA, and it effectively is around the pricing of pharmaceuticals. And we'll get into here a moment in terms of who qualifies to participate in 340B. But the purpose of it was to stretch the federal resources and expand healthcare services. In terms of who qualifies for 340B, you'll see here, these are the covered entities. So you'll see in the bill, lines 15 through 18 is covered entities, and they do a nice job explaining that in 4 or 5 lines, but I thought I would give you just the bulleted list. These are the hospitals and the clinics and the federal grantees that are effectively capable of leveraging the 340B program. In the state of Georgia, for the hospitals, we have 70 hospitals that take advantage of this. And for the clinics, my apologies, I didn't get the exact number, but I know that is more than 70. In terms of the intended benefits of the program, and again, I don't like to read to people, but effectively, if you can imagine a time where when we're looking at the underinsured, the uninsured, Medicaid, et cetera, the idea was to be able to provide reduced cost drugs to safety net providers, pure and simple. I can keep going through in terms of what the intent was, but if you look at the 2 ways that this is funded, effectively it is either A, direct low-cost benefit to the consumer, to the patient who needs it. That, again, that's the underinsured, uninsured, cash pay, et cetera. And there is an intention inside of the statute for if there is money made, so there's absolutely acknowledgement of that. That money made needs to go to a public benefit. And I'm going to get into that in one moment, what that public benefit is. But if you can think about individuals who can't afford cancer treatment, can't afford dialysis, can't afford diabetes drugs, et cetera. How the savings work, I just went through that in some extent, but effectively, if you can imagine, it is a lower cost price from the pharmaceutical companies being provided to the 340B covered entities. The covered entities enter into a contract, if I could direct you to the bill, to contract pharmacies, and that is lines 12 through 14. Those contract pharmacies are essentially required to be able to distribute, vis-a-vis proper payment, the drugs. Now, let's just go ahead and stop here for one moment. We can have public hearing all we'd like, and of course we're going to. This is a hearing only. I'm just going to give to you what you're going to hear from the opponents, and then I'm going to give you what you're going to hear from the proponents. At the end of the day, this is not legislation on 340B. That conversation should be had in D.C. And by the way, I would encourage anyone who thinks 340B should be changed, run up to D.C. and enjoy yourself with the 435 in the House and the 100 in the Senate. This is a conversation about Georgia. But what you'll hear from the opponents, and I mean this respectfully, because I have spoken to them respectfully, is only 1% of the 340B benefits are going to the intended populations. 340B is not applied as intended per a North Carolina study that they were kind enough to give me. They may have given to you if you read that through. You'll see that they talk about over 1,500 contract pharmacy. where in a sense, this law is being perverted in the state of Georgia. You'll also see comments around this is not taking into account independent pharmacies. It's not taking into account those individuals serving rural and urban. This is just handling the big box and the brand pharmacies. And the intent of some of the folks on the opponent's side is we believe, or they believe, pardon me, that the covered entities should only contract with one covered pharmacy. 340B does not provide for that. Period. End of story. It says one or many in the statute. And in addition, Georgia rules through the Board of Pharmacy says that the consumer will be able to choose their pharmacy. So what are you going to hear from the proponents? 9 states have already done it, including 3 SEC states, which is always important to note in Georgia. There are 10 other states with legislation in 1 or 2 chambers right now. By the way, 3 of those chambers have already passed at least one part of this bill. There are actually 505 discrete, not 1,500 plus contract pharmacies. And I want you to imagine down in rural Georgia, we don't have a covered entity for every county like we do necessarily in some other parts of Georgia. So covered entities will have multiple covered pharmacies. The BOP, like I said, talks about the right of the patient to choose his or her pharmacy. Over 25% of the covered pharmacies are independent. Others are CVS, Walgreens, Publix, Costco, the crew, go on and on. They just turned me off because they don't like my PowerPoint. The Arkansas law, which this bill is based on, I'd rather call it Arkansas if you don't mind, because I don't understand the difference between Kansas and Arkansas in terms of the way we say it, was upheld. And then finally, the 340B proceeds are needed to serve the uninsured. So guys, this isn't a debate on 340B though. This is a debate on what we do here in Georgia. So my feelings was to give you very quickly what are 3 things happening in Georgia in terms of the use of 340B. Right now, Chris Regional gets around $2 million based on the 340B program. That's based on the pharmaceutical cost savings they have. Their payer mix, you can see right there, is 70% Medicare, Medicaid. And their savings allow them to offset for other programs, and I'll get into that in a moment. And I know I'm going to say it wrong because every time I say Colquitt, someone from Colquitt tells me I'm saying it wrong. Colquitt. But ultimately, you can see that for 18 years, they have used this program, that over 90% of the savings are going to 3 major things. Cancer services, which just last year they did $2.2 million of uncompensated care. Dialysis services, which you can see is 100% of a Medicare patient mix. And then finally, the repricing of medications for their correctional facilities. For those who do not know, correctional facilities take in a significant amount of drugs, but also a significant amount of doctor services and mental health services. And then finally, Wellstar wanted to just add this in terms of what they have been able to save. You can see there nearly $250 million, providing about $1.3 billion in charity and uncompensated care. Again, this was part of their ability to do $1.3 billion of uncompensated care, but ultimately gives us a sense of where we're at and what the community benefits are. Just the second bullet point alone. I mean, I know that I have family members with breast cancer, colon cancer, prostate cancer, and lung cancer. So I hit all 4 of those in terms of my family tree. Just the screenings alone to me are worth their weight in gold. And then finally, the conclusion. I believe that I could sit here with you and debate the merits of 340B in terms of whether or not inside our state we have individuals that are being bad actors. I would suggest to you, unfortunately, there probably are some bad actors in our state. But I would suggest to you a preponderance, or I would say a vast majority of the actors in our state are good actors. Let's not penalize the good actors because of the bad actors. I would rather us work really hard to find the bad actors, find them out, suss them out, penalize them, and get them to the federal government. So what the bill does in 36 some odd lines is this. It effectively directs the pharma companies, the PBMs, the wholesalers, etc., to effectively follow the law. That's what it does. Follow the law. The federal law preempts us. And it says very clearly that the covered entity, assuming they meet that requirement, can in fact contract with 1 or more contracted pharmacies. Mr. Hawkins, or Dr. Hawkins, thank you very much for the opportunity to present.
Representative Newton.
Well, that was a great primer on the 340B program all the way back to its origin and the clarification that it is a federal plan. I have one area in the bill on lines 27 through 30 that kind of seem to go a little bit different from a direction we've been trying to go in this body for several years, and that has to do with transparency. This has a line that says, like, nobody directly or indirectly can require, under line 28, require a covered entity to submit any data. And you're a data guy if there ever was one. I'm just curious. I know this is a hearing only, and maybe we can talk about it a little bit more. The descriptions you gave, which were very profound, the amount of money that this is being used for and the care that's being used. And I know we've talked before about whether the list price of charity care is really a fair estimate of the charity care. But separate from that, we've been trying to enhance transparency. I do wonder if there's a way in the 340B program that the numbers you gave are what's going with the law as it is now, which I believe is the company's able to restrict hospitals maybe to one pharmacy. It's not all Colquitt, and it's also Northside and CHOA and some other hospitals that are pretty big. It might be helpful to, instead of prohibiting data sharing, to maybe come up with some language to where we actually can get an idea, both where we are now under the current law and if this bill passes, where we would be going forward, to better be sure that the efforts we're making are really going to the charitable mission, which you so clearly described in the beginning. Would you be open to discussing ways to add transparency?
Yeah, so Dr. Newton, 100%. We're trying to stay as close to the Arkansas bill as possible, but that stated, I think that it is important that we have that conversation around transparency, because to me, I want to make this a Georgia law as much as possible, but staying as close as we can to Arkansas.
There are
it has
other
been
states
upheld.
that have added transparency.
100%.
Thank
Yeah,
you.
so I would like to, and we can work together.
Sir.
Okay, any more questions? I see none. We've got a few people here to testify. We'll do the Zoom there. Let's go ahead and do, I want to do these. Michael Zonin, Azzolin. Michael?
That was good enough.
Yeah. Would you like to come up? You can use this mic.
Mr. Chairman and committee, I appreciate your time. By way of background, my company supports rural hospitals primarily in overseeing 340B program. We actually manage pharmacies inside of hospitals. We also manage a couple of hospitals here in Georgia under Alethea. And a lot of what Representative Jones already touched on really has changed my thought process of what I want to say, because I'm ready to get out of here too, go home because my kids have a baseball game, but this is a very important issue. And to his point, in a vacuum, I would philosophically disagree with the concept of the program in a vacuum. But the issue is it doesn't exist in a vacuum. In hospitals, particularly those that are reimbursed by Medicare, are required by EMTALA, which stands for the Emergency Medical Treatment and Labor Act, required to see patients who cannot afford or don't have insurance to pay for their health care whenever they go to the hospital. Some of those hospitals that were mentioned earlier, the disproportionate share ones, in fact, and by the way, one of those requirements is those hospitals have to be nonprofit. They can't be for profit in order to receive the 340B medications in outpatient areas. But for disproportionate share hospitals that are not sole community hospitals, they have to see 11.75% over the national average indigent patients before they can qualify. They don't just automatically qualify. So the question it's already been articulated well, and I think we all can probably agree that it's a federal program that we really don't have any jurisdiction over. The question is not whether or not you agree or disagree with the premise of the program, but more so how medications that are eligible get distributed to patients. And that's what matters. And right now in the state of Georgia, the primary mechanism for that happening in outpatient areas is pharmacies. And to Representative Jones' comments earlier, in Georgia, patients have a choice of what pharmacy they can use. So if pharmacies are restricted, certain ones are not allowed to contract with hospitals, and a patient chooses to use that pharmacy, then it directly penalizes the covered entity or the hospital. from their ability to utilize a program that's been federally approved already and obtain the medications for those patients. And keep in mind now, it was read earlier, but I'll reread it. This is directly off the HRSA website. The 340B program enables entities to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. The purpose of the program is not directly to provide lower cost medications to patients. It's to offset the cost of covered entities for the fact that they have to see indigent patients so that they can continue to provide medical support to those patients and others. So what are some of the implications associated with manufacturer restrictions on medications? In some of the hospitals we service, I have permission to use their actual hospital name. Jefferson Hospital in Louisville, Georgia, in 2020 had saved $408,000 on 340B drugs. After manufacturer restrictions, they were only allowed to contract with one pharmacy. And as a result, their savings went down to $247,000. As you can imagine, they chose the one that saved them the most money, but they had to sacrifice the rest. Emmanuel Medical Center has a very unique case. They actually have a retail pharmacy inside their hospital. It's inside their hospital pharmacy, actually, but it's not outward facing. So it doesn't provide medications to patients of the community. It provides medications to their employees because they're struggling and they're trying to find a way to save money. So they're using their in-house pharmacy to dispense medications to their employees. But by virtue of the fact that they have that retail pharmacy inside that hospital, the manufacturers are not allowing them to even contract with one contract pharmacy. So as a result, in 2020, they saved $761,000 on 340B drugs. As of 2024, they saved $1,677 on 340B drugs. They can't access them because of these limitations. And again, it is a federal program that allows these hospitals to have them. Memorial Health and Manor in Bainbridge, Georgia, went from $916,000 in 2021 to $525,000 in 2023, and is down to $250,000 in 2024. Again, because they can only contract with one pharmacy. The other thing this does is it excludes pharmacies who want to participate but can't, because the hospital is only going to choose the one that generates the most savings. And that, even though it's not meant to force a patient to use a particular pharmacy or another, will have influence. And that is not what the spirit of the Board of Pharmacy rule is in 480-5. There's also a law, it's in Title 31, it's relative to nursing homes, but it directly states that patients cannot be told what pharmacy they had to use. That's all I have to say. I had a lot more, be happy to talk more, but I think between the two conversations, every point I wanted to make was made. Thank you.
Thank you. Okay, I see no questions. Let me see. Let's go down to Penny Knight or Penny Knight or Perry Knight. Okay.
Good afternoon, Chairman Hawkins and members of the committee. My name is Perry Knight. I am a Vice President of Law at Johnson & Johnson Innovative Medicine. Johnson & Johnson is proud to call Georgia home to several of our manufacturing facilities. I'm here today to share our concerns about HB 139, and I'd like to emphasize three main points. First, Johnson & Johnson supports the original intent of the 340B program. We believe it should be preserved and protected for the vulnerable patients and the hospitals and health systems that truly serve them. 340B plays an important role in the healthcare safety net, and we have tremendous respect for the providers that are using the program the way it was intended. Second, 340B has grown far beyond that original intent, with large for-profit corporate interests capturing a growing share of the 340B discounts. This leads to abuse of the program, which drives the benefit away from vulnerable patients that it was intended for and increases the cost for states and employers. And third, it's been said before, I'll say it again, 340B is a federal program. It is intricately connected to other federal programs like Medicare and Medicaid. We strongly support federal reform of the 340B program, starting with transparency that can drive accountability to ensure that the program truly serves vulnerable patients. There are a lot of misconceptions around 340B. I've worked in the 340B space actually since 1992, since the law was passed. And I can tell you this is no longer, it maybe once it was intended as, this is not a patient discount program. The overwhelming majority of patients that are served and who have 340B drugs purchased on their behalf actually don't see any of the discount. So 340B and how it works. Again, I've been there since 1992. I've been working on this program for 33 years now. 340B was intended as a buy low, sell low program that directly benefited vulnerable patients. I worked in one of those hospitals for about 10 years. However, it has become a buy low, sell high arbitrage opportunity for for-profit national chain pharmacies and vertically integrated PBMs. Quite simply, they leverage the low 340B prices, they charge patients full price, and then they generate high profits in between those two. But it's a critical problem with this program that there's no requirement that 340B hospitals use these profits to benefit vulnerable patients. Patients don't benefit from this program by and large. And with contract pharmacies in particular, what we've seen is actually the opposite of what you would want from this program. We're seeing expansion into wealthier neighborhoods. And here in Georgia, 35% of contract pharmacies are located in affluent neighborhoods. There are over 3,300 arrangements between for-profit contract pharmacies and 340B providers. Over 1,600 are with pharmacies that are out of state, as far away as Hawaii. Overall, it's been estimated that only 1.4% of patients get to share in that 340B discount at contract pharmacies. Another point that I would make is that 340B is not free. This is not free money by any stretch of the imagination. There's a growing body of evidence that shows 340B raises costs for others in the system, including employers and state and local governments. So for employee health plans, how this works is the 340B discount displaces commercial discounts. The 340B discount goes first. 340B goes first. Other programs such as Medicare, Medicaid, TRICARE, commercial insurance, state and local government employers, their discount, if any, comes after. But if there's been a 340B discount first, then the other payers and the other programs don't get those discounts. So there was a recent report that came out that looked at this dynamic, this rebate replacement dynamic. And it said specifically for Georgia employers, 340B is costing them $187 million annually in lost commercial rebates. And it's costing state and local governments about $27 million annually. 340B is not free. If you expand 340B into contract pharmacies, which are nowhere in the federal statute, I'll add, that would add another $25 million in cost to Georgia employers and employees. Another factor to consider in looking at expanding 340B is hospital markups. The average per patient spend on outpatient drugs at a 340B hospital is more than 150% higher than at a non-340B hospital. A recent report from North Carolina Treasurer found that 340B hospitals marked up oncology drugs an average of 5.4 times when billing state employees. That was 85% higher than the markup at non-340B hospitals. That is something to consider. It should be interesting to see what those figures look like from a Georgia standpoint. You should also consider how 340B incentivizes provider consolidation, which can raise employer costs by pushing patients into higher cost sites of care. The last component of this that I'll mention is litigation, and admittedly, I'm a lawyer. Unfortunately, legislation like HB 139 that has been introduced into other states has done nothing to address the abuses that we see in 340B or ensure that vulnerable patients are actually benefiting from these discounts. Instead, where states have passed the legislation, they've been faced with ongoing litigation. And that is centrally because 340B is a federal program, back to my initial remarks. There are significant and very real constitutional issues with states legislating a federal program like 340B. Indeed, there are 22 active federal litigation cases in these states. So we would urge you not to move forward with similar problematic language and legislation in Georgia. And again, I'll just close with this. Johnson & Johnson is committed to the 340B program. We will continue to advocate to ensure that it truly benefits patients as it was originally intended. Thank you very much.
Thank you. Next up, Becky Riles.
Chairman Hawkins, members of the committee, thank you for this opportunity to share with you today. I'm going to come from a very different perspective of the 340B program. And that starts with the origination of federal legislation which established community health centers in your districts across the state and across this nation. Also known as federally qualified health centers, they receive a federal grant in order to be able to provide primary care to patients who are uninsured and underinsured. So let me make sure we're all on the same starting point. Community health centers were established to provide access to care in communities that are underserved. So patients were not able to find a doctor who would see them, or they couldn't travel to the nearest physician to have a medical home. The purpose of establishing federally qualified health centers is so that individuals can have access to primary and preventative care to keep their health issues from escalating to far more serious health issues. So community health centers were established over 60 years ago. Then fast forward, when Congress decided that in order for patients to truly be healthy, they must have access to primary care, but they also need access to prescription medications. And so for an individual who has been diagnosed with diabetes, if they don't have access to insulin and the strips that are necessary to become compliant with how to keep their diabetes under control. If an individual is diagnosed with hypertension and they don't have access to the medications, then their health status, of course, will decline. I say all that to share with you that patients at a community health center pay about 1/3 of the cost for their prescription medications. They pay 1/3 of the cost of their prescription medication. The 340B discount program at a community health center is a pass-through for the patients to be able to access the medicines that they need in order to improve their health status and their quality of life. I didn't even start looking at my notes yet. So let me just sum it up. I think I will just say that, remind you, each of you had this map on your desk last week when health centers had their day at the Capitol, and I'll just pass this around, and I have more if you would like another one. Chairman Jones, currently in Georgia, there are 35 health center organizations, plus one lookalike, which we'll explain that later. They are located in 330 clinical sites in this state. And just to speak to the challenges that health centers alone have faced with restrictions to one contract pharmacy, keep in mind that health centers are 501c3 nonprofits. They are governed by a local board of directors, 51% of which are patients. So these are community leaders deciding what are the health services that are needed. And so the first thing that these locally based groups and community-led organizations Guess who they want to contract with first? Their local independent pharmacy, of which there are fewer in rural Georgia, but health centers want to do their part to support the local and independent pharmacy. And so for a health center in South Central Georgia serving 14 counties, when you have to choose one contract pharmacy, then that is a significant burden for patients to travel to access their medicines needed to improve their health status. So I'm going to close with this. In those 330 clinical sites last year, health centers saw 700,000 patients. 700,000 constituents of yours fortunately have access to primary care and preventative care and have a medical home. We ask you to we ask you to pass HB 139 so that patients in your districts can continue receiving the medications that they need. Thank you.
Thank you. Okay, up next, Travis Pacello. Travis. Okay, that's one down.
Right here, Mr. Chairman.
How about Sharon? Oh,
Unfortunately, no.
darn.
That's right. That's right. Thank you, Mr. Chairman, members of the committee. My name is Travis Buccello. I am the Director of State Government Affairs for the Healthcare Distribution Alliance. We are testifying today in respectful opposition to House Bill 139 and are requesting the committee's consideration today of an amendment to strike us from the bill, addressing our concerns. HDA is the National Trade Association representing pharmaceutical wholesale distribution companies. Our members serve as the vital link within the supply chain, connecting over 1,200 pharmaceutical manufacturers with more than 350,000 pharmacies and healthcare settings around the country. This includes approximately 8,000 in Georgia alone. In addition, our members proudly employ over 4,000 Georgians and have distribution facilities all around the state, including in Beaufort, Valdosta, and Tifton. Simply put, HDA members provide the logistics expertise to ensure that pharmacy and hospital shelves are stocked with needed medications to treat their patients on a day-to-day basis. The stated intent of House Bill 139 is to prevent 340B manufacturers and distributors from interfering or denying the sale of those drugs to a 340B covered entity. However, the language of the bill, from our position, unnecessarily includes wholesale distributors, and we respectfully request the removal. Inclusion of us in this bill in the language would conflict with our obligations under federal law, including those under the Federal Drug Enforcement Administration, or DEA, with respect to how we handle orders for controlled substances, as well as contradict some of our members' obligations under the National Injunctive Relief Settlement Agreements to which Georgia is a party to. These challenges would result in a wholesaler being placed in, frankly, an untenable position. We would be forced to either follow federal law or follow state law with respect to the delivery of these controlled substances. That concludes my testimony. It was short and sweet. I'd be happy to answer any questions you may have at this time.
Thank you. I see no questions. Sharon Lamberton.
Thank you.
Lamberton.
Thank you, Chair Hawkins and members of the committee. My name is Sharon Lamberton. I'm a nurse by training, and I've been with Pharma, the Pharmaceutical Research and Manufacturers of America, for almost 20 years now. We represent 30 drug companies that make brand name medicines, treatments, and cures. And I'm here today to respectfully oppose this bill because it absolutely will be the wrong answer for Georgia. And I want to tell you that in about 5 points. But first, it's interesting because we heard from Becky, and she does incredible work. I worked with FQHCs and RHCs, and they are incredible people. They are the good actors, but they're a small part of this overall program. And when you look nationally, you have to look at the big picture before you do something to the state of Georgia. that could be codifying fraud. And I say that with real purpose because when you look at 340B, it was intended for patients, the underinsured, the uninsured, those that could not afford medicines. You might hear from opposition that pharma or companies want to dismantle 340B. We do not. We are the 340B program. It's the second largest prescription drug program in the country after Medicare Part D. It's now $66 billion, and that's real money because we put in a lot of money to bring a drug to market, to bring it through from bench to bedside. And then we put in the additional money so our patients can have access to the treatments that we're bringing to market. So you might say, Sharon, where's that $66 billion coming from? It's coming from our companies that give, and I would take exception with several of the slides that Representative Jones put up there because it was inaccurate in a couple ways. And one way was it doesn't provide discounted or free medicines. It gives a significant deep discount on medicines. That's about 60%. So I like to do easy math. Let's pretend the drug is $100. And even a 50% discount would mean that drug is $50. So that means that hospital, that not-for-profit hospital, or that clinic can keep that spread. Well, back in 1992, that was absolutely what Congress intended. They wanted the safety net providers to keep that spread and give it and put it toward the patient that needs access to those medicines. But it's going everywhere but to the patient. And in Georgia, I would like to say there are a lot of good actors, but I would be remiss if I didn't bring up the federal government's audit in Georgia. You had mentioned it's true there's 70 hospitals that are 340B hospitals, but when there was an audit, they did 51 audits, 34 audits came back showing illegal distribution of funds. We need a federal fix to this federal program, and I absolutely respect the work that you're putting into it, Representative Jones and all the members here, but we do not need to tamper with 340B on a state level until we can have that federal fix. And we got really close, and I'm hoping we get close again in Congress with Cassidy's work and some of the work that they're doing with other senators. So I'd say in just a quick few points, because I don't want to reiterate what the other folks have said, but I would say that 340B is just not working for a number of reasons. Does it benefit the patient? It absolutely does not. It gives patients a 1.4% discount on medications when the hospitals, the not-for-profit hospitals, and the CEs are getting over 60%. So the patient is paying. Employers are paying. Here in the state of Georgia, employers spend over $187 million in increased healthcare costs because of foregone rebates, because of the 340B program, which drives up the cost for everyone. And then you have to look at the middlemen. You have to look at who's getting the money. It's the large for-profit chain pharmacies that are owned by PBMs. And this is over half of the profit. In fact, 68% here in Georgia of those contract pharmacies are the big four. The big four pharmacies, Walgreens, Walmart, Secreto, we need to make sure that we return this program to its intended purpose. Patients need it. Providers need it. We want to see our medications that we work 12 to 15 years to bring from bench to bedside, and 88% of them are failing. We want to see that drug get to the patient. We also, in addition to this program, spend $23 billion in patient assistance. That's $23 billion in addition to R&D to bring that drug to market. We want to give it to patients so they can afford our medications. So when it's not benefiting the patient, it's driving up the cost for employers. It's driving up the cost for the state. And you referenced the North Carolina study. That is actually a very important study because it's North Carolina Treasurer's report that saw the medications were marked up 84% for state employees. And that's bad. That is a horrible cost to patients and to the state. And then it's not improving health outcomes. If it was doing as intended, you would have seen lower death rates. You would have seen improved health outcomes. We're not seeing that. And we're seeing expose and report and investigation on investigation that is highlighting this misuse and abuse. So I would just say in conclusion, we appreciate the efforts here of the sponsor, but I would love to be able to implore you and everyone to think about the program. How is it being used? Not just here in the state of Georgia, but everywhere, because it is getting litigated in 8 states that tried to replicate this program. And we need a federal fix. We're getting close, and we want to make sure to return this program to the patient, not for the for-profits that are taking over half of the profits. And then finally, Georgia has very rural areas. When you look at where those existing contract pharmacies are, there's only 1/4 of them are in rural areas, 17% in low-income areas. So again, these entities that are making a lot of money aren't in the neighborhoods where the patients are living. Thank you for your time.
Thank you very much. That was very detailed. Okay, we're going to go to our virtual speakers now, and I would ask each one of y'all to please be brief and speak directly to the subject and not repeat some of the information we've heard so far. We're ready to go on that. Maria Thacker.
Yes, sir. All right. Yes, sir. And my apologies for being in the car. I am playing mom today with my daughter home from school. So thank you, Chairman Hawkins and members of the committee, for allowing me to provide testimony here. My name is Maria Thacker Gothi, and I serve as president and CEO of Georgia Life Sciences, formerly Georgia Bio, as some of you may know us. We're an organization that represents nearly 4,000 Georgia companies dedicated to advancing healthcare innovation, fostering a strong life sciences ecosystem, and ensuring patients across Georgia have access to safe, effective, and affordable medications. Our industry encompasses biotech, medical devices, pharma, digital health, research institutes, global public health, food and ag organizations, and industrial biotech. While the intent of HB 139 is to expand access to discounted medications, and it may seem beneficial on the surface, Georgia Life Sciences and our board are deeply concerned about the unintended consequences of this bill and how it could impact patients, independent pharmacies, and the integrity of Georgia's pharmaceutical supply chain. As others have stated, the 340B program was originally designed by Congress to help safety net providers serve vulnerable patients by offering prescription drugs at discounted prices. However, the program has expanded significantly over the years and without sufficient oversight. There is growing evidence that these discounts are not always reaching the patients who need them most. HB 139 could worsen these efforts by failing to ensure patient savings, creating cost shifts in the market, and reducing access in rural and underserved areas, as the previous speaker mentioned. If HB 39 enables broader pharmacy participation without transparency requirements, it could hinder Georgia's ability to help patients in need while allowing PBMs to generate sufficient revenue and profit at their expense. Rather than moving forward with HB as written, I urge the committee, and Georgia Life Sciences urges the committee, to consider alternative approaches that would protect patients while maintaining the integrity of Georgia's healthcare system, such as requiring increased transparency, implementing stronger oversight, and safeguarding independent pharmacies. As Georgia continues to strengthen its healthcare system, we must be careful not to enact policies that create more harm than good. 340B is federally directed and regulated. The last thing patients need is a patchwork of laws at the state level creating differential access. While I believe HB 139 is well intended, it risks worsening inefficiencies within the 340B program, ultimately driving up costs and creating new vulnerabilities in Georgia's healthcare landscape. On behalf of the industry we represent, Georgia Life Sciences, again, has significant concerns about legislation that would forbid companies from implementing methods of transparency within a rapidly expanding program like 340B. I urge the committee to take a more measured approach that prioritizes patient savings, transparency, and market stability. Thank you for your time and consideration, and I'm always available to answer questions now or at a future time.
Thank you very much. I appreciate
Yes,
it.
sir.
Next up, Mark Howell for GlaxoSmith.
Yeah, thank you, Mr. Chairman. Can you all hear me okay?
Yeah.
Great.
Chairman Hawkins, Representative Jones, and members of the House Committee on Health, thank you for the opportunity to testify today on House Bill 139. As we've discussed, it's related to the 340B drug discount program. And in particular, I know Representative Jones and I were unable to connect prior to today, and so we would certainly offer the opportunity to provide additional resources moving forward. As the chair mentioned, my name is Mark Howe. I'm a director of 340B policy at GSK. We are a science-led global healthcare company focused on preventing and treating disease with vaccines, specialty, and general medicines. At GSK, we support policy solutions that transform our healthcare system into one that rewards innovation, improves patient outcomes, and achieves higher value care. I'm here today to urge the members of the committee to vote against HB 139, which would require drug manufacturers to provide discounted 340B drugs to an unlimited number of contract pharmacies without providing sufficient safeguards to ensure program integrity or direct patient benefit. As you all are aware, the 340B program, it's been mentioned before, is a federal program. It's administered by HRSA, and it allows eligible hospitals, clinics, and other providers known as covered entities to buy prescription drugs at lower prices. However, hospitals often sell these drugs to patients at a significant markup. In fact, since 2010, these covered entities have been able to contract with pharmacies to dispense 340B drugs to patients in an expansion of the program. When Congress created 340B, it intended for the program to be a financial lifeline for institutions that deliver healthcare to underserved communities. The goal was to ensure that those providers could use the savings generated by the program to invest in critical services that directly benefit low-income and uninsured patients. However, the discounts are not required to be passed on to patients, and Congress did not include adequate safeguards to require that the markup charged by the hospital is reinvested in patient care. I want to be clear and say that GSK supports Congress's original intent for the 340B program to benefit those vulnerable patients, but we remain concerned about the lack of guardrails and safeguards in place, as well as the perverse financial incentives that instead benefit the middlemen that are driving programmatic abuse. Those include for-profit chain contract pharmacies and third-party administrators. In addition to this abuse, we continue to see expansion of the 340B program into wealthier communities through an increasing number of contract pharmacies and covered entity satellite clinics, often referred to as child sites. Between 2012 and 2024, 2 out of every 3 new contract pharmacies established were in wealthier, advantaged areas. Meanwhile, low-income areas are left behind. In Georgia, only 17% of 340B contract pharmacies are located in zip codes where average household incomes are below the state median. Patients often do not benefit from the significantly reduced acquisition cost for hospitals. In fact, and this has been referenced, the North Carolina's Treasurer's report found that hospitals in the state collect as much as $6,000 per claim. And I do want to highlight here that we saw through that report that in some instances, there were markups at 12.7 times higher than 340B acquisition cost for outpatient infused cancer medicines. At GSK, we are highly concerned that HB 139 will further accelerate the abuse and the costs of the 340B program to the state without proving its integrity. The 340B program is a federal program warning a federal fix. GSK and others are working with Congress to pass a comprehensive 340B reform package focused on ensuring integrity and providing direct benefit to patients. For these reasons, we urge you to vote against HB 139 and instead focus on improving transparency in the 340B program. We applaud this committee and the Georgia legislature for its prior work on surprise billing, hospital transparency, and provider disclosure. We encourage you to explore ways that we might improve transparency and integrity in 340B. This could include a study bill that looks into how 340B revenue is used by covered entities. For examples of successful efforts there, we would encourage you to look at the recent reports from the North Carolina State Treasurer and the Minnesota Department of Health. Thank you for your time and consideration. I fully appreciate how busy this committee is, and I want to convey my gratitude for your attention to this important matter. Happy to answer any questions on 340B now and welcome the opportunity to meet with you and your colleagues in the future to discuss the program, the unintended consequences of this legislation, and how 340B's misaligned incentives directly impact the people who live in the great state of Georgia. Thank you, and happy to answer any questions.
Thank you. I see none. Thank you for your time and your testimony. Okay, up next, Robert Pavoyan, I guess.
It's good enough. It's good enough. Thank you.
Okay.
Can you all hear me? Because there's some construction going on outside, and I want to make sure everything is okay with the hearing part.
Yeah, no,
go ahead. So my name is Robert Popovian. I am with the Pioneer Institute. Pioneer Institute is a free market think tank based in Boston, Massachusetts, similar to the Georgia Public Policy Foundation, which is based in Georgia. We're here basically for the 340B program to create an environment where there's real data that is able to be used by legislators, both on the federal and the state level, to make informed decisions. About 3 years ago, Pioneer Institute launched a tool that is available on our website to anyone who's interested to take a look at the actual numbers for each state, not only each state, but also each legislative district, whether it's the Senate or the lower house, and see what is the expansion of the 340B program. The key here is transparency, and we are all for transparency and something that we champion. There's a few things you need to know about Georgia and the 340B program. Number one, about 30% of the contract pharmacies that work with hospitals in Georgia are based outside the state. But when you focus on the top 5 hospitals with the most contract pharmacies, 60% are outside the state. The most recent data based on the census information and HRSA data tells us that 57% of the pharmacies within the state of Georgia are actually in affluent neighborhoods, not in the poor neighborhoods that these patients live. So for that reason, and also because you can see from our data, by the way, the data on the Pioneer website is either from HRSA, the Census Bureau of the United States, or from the RAND Corporation with regards to the charity care. Anyone and everyone can go on the website and take a specific look, and we boil it down to individual pharmacies, to individual hospitals, to individual clinics. We also look at individual, as I said, legislative districts and house districts, and you can take a look at it. This program requires more transparency than less transparency, and any bill that prohibits any type of transparency with it and restricts transparency is going to basically create the problem where you see more and more of this type of environment where these pharmacies are not either within the state, or when they are in the state, they're in the affluent neighborhoods and not the poor neighborhoods that patients live. My final say is that the representative who authored the bill is correct. There's a significant number of independent pharmacies that participate in the program. But if you look at the data, again, our data is from the HRSA, it clearly shows that the top 5 pharmacies with the most contracts within the state of Georgia are either chain drugstores, like consulting firms, or PBM-owned pharmacies. These are not independent pharmacies. This is not about independent pharmacy access. This is all about the PBMs and the chain drugstores taking advantage of a federal program to the detriment of patients. And as it's been discussed before, none of this savings really going to the patients. But with that said, I will be happy to answer any questions. Again, I urge you to go to the Pioneer website and learn for yourself where all of this data came from.
Thank you. Thank you for speaking to us. I appreciate it. Okay, up next, Dorothy Glasser.
Thank you, Mr. Chairman. It's a pleasure to be in front of you again and committee members. We are the Advocates for Responsible Care, and we lead the Georgia Coalition. We are a 50-member organization of all patient and health-centered organizations that come together to be able to provide and help patients have access to their medications, their treatments, and their care in Georgia. We oppose HB 139 because, as has been so eloquently stated, most of these pharmacies are not in the neighborhoods for the patients who need the benefit of this program the most. We get calls every week from patients who say that they can't afford their prescription drugs, who are in these neighborhoods where 340B is available to them. So as patients, we're asking, why would we cherry pick a piece of legislation and picking out about what contract pharmacists can do when in fact the entire program needs complete reform from the federal government down, and there are bills right now that are on the table to reform this program. This sounds to me like this bill, though good intentioned, is really for the people who are making the most profit off of the backs of these vulnerable patients. We ask you to please do not pass 139 because with this 340B will continue to be a failed program without guardrails, without transparency and accountability and oversight, while hospitals and contract pharmacists will continue to profit at the expense of Georgia's most vulnerable patients. We're asking you to please help the patients and put them first and not the people who are making the most profit. Thank you.
Thank you very much. That is all I have on our list. So I want to thank everyone that came here today, and we'll see where we are next week on this. Thank you. Meeting adjourned.
Oh, is it? Yeah. Oh my God, that's awesome. You know?
I'm not a bit.
Oh, I'm saying, yeah.